Hello, my name is Ian. Welcome to the Royal Berkshire Intensive Care Unit. Hopefully over the next few minutes we'll be able to show you what sort of patients come here, what sort of staff we have working here, and we'll also go through the pioneering aftercare patients get on the Royal Berkshire Intensive Care Unit. Hopefully this short tour will strip away some of the mystery that surrounds intensive care with all the complex machines that people often see.
One of the main differences between a generic ward in the hospital and intensive care is what's known as the acuity of patients, or actually how sick the patients are in intensive care. And the easiest way to describe it is the patients in intensive care are the sickest ones in the hospital, and therefore they need the highest level of nursing and doctor input. So 90% of patients that come into intensive care get one-to-one nursing, and that means that there is a nurse in their bed space or around their bed space almost every waking minute of that day and night. There's a consultant responsible for the unit every day, and we do at least 2 ward rounds and have a doctor in the unit at all times. The kind of patients that are admitted to intensive care are quite varying of range. Some of them are patients that may have had road traffic accidents or any kind of accident really that requires them to have some kind of support, such as being put on a ventilator to help with their breathing, and a mixture of patients that have post-operative care needs depending on the length of their operation or what they've had done to them.
The patient arrives usually with a team which would be normally a doctor and a nurse and support staff to help move the patient on a bed. They'll come into a room such as this, have to be carefully transferred onto this bed, and then everything will be modified so they go onto our breathing machine, such as the one here from the portable one that they came with. All their infusions and drugs will be transferred to a new system such as that stack over there, and they'll be connected to one of our monitors, and we can monitor anything we want to. Usually it's the ECG, the blood pressure through directly from an artery line. We can measure what we call central pressure from the veins in the neck. We can measure the oxygen levels, the CO2 levels. We can even measure the pressure in someone's head. So the monitors give you a continuous readout what the patient's doing. If there's any abnormality, we can immediately act on it. All the data will then get transferred as it's processed through to our central computer. In the old days, if you had a patient in intensive care after a month, you could accumulate several volumes of notes, which are very difficult to decipher and to make any sense of. So now we have a computerized record of their stay in intensive care. For a relative to come into an intensive care unit with all the array of machines can be very frightening, and the thing they should expect is for one of the staff to explain everything in detail to them. It's not actually very complicated when you break everything down. There are several forms of machines that we use on intensive care, and the most common one that people are familiar with are the ventilators. We used to have these things with big bellows that you could see going up and down, and the problem with those machines were that it was very difficult for patients to synchronise with them. One of the issues with patients on intensive care is you often have to sedate them, but sedative drugs have side effects, so we try and sedate them as little as possible, and that's made possible by the modern day ventilators, which just really add to what the patient needs rather than takes over their breathing completely.
Each patient is treated individually, and sedation is varied depending on what's wrong with the patient, how long we think that they will stay ventilated. We also obviously add in pain relief with the sedation, but every day we assess people's sedation levels and their pain scores and see how arousable they are to make sure that we are keeping them as lightly sedated as possible to not prolong their length of stay in the unit. Patients may stay 24 hours post-operatively, or depending on their condition, some patients may stay weeks or even a couple of months. It really is dependent on that patient and what they have come in for.
My memories of being a patient in intensive care are really somewhat limited because of the 30 days I spent in intensive care. I was probably only aware of what was going on for 10 of those days. But the experiences range from frustration with not being able to talk to fear with regard to the hallucinations that I had at the time. Most of what happened to me in intensive care came from what my relatives and friends had told me after being discharged from intensive care.
Memories of being an ICU patient. I think I recall someone actually saying, "You're going to ICU." And then the next thing I knew, I woke up in the intensive care unit. At the time, I didn't know why I was there, how long I'd been there. I didn't know why I couldn't communicate or speak. Obviously, I found out it's because I had a tracheostomy, which was helping me breathe. And it's a very long and slow process to try and ask people the thousands of questions that are going through your head of why you're here, when are you going home, why aren't you taking me when family and friends visit, why aren't you taking me home with you? And again, it's just a very, very confusing time because there's so many questions you want to ask.
My hallucinations occurred after I'd had surgery. They were as real today as they were then. My hallucinations related to one of the nurses in the ward trying to kill me. And when I was trying to explain this to one of the nurses, I asked for all my family and my relatives to be moved from the bed. And I talked to her for a very long time and was very concerned that that nurse would continue to try to kill me, although I was now conscious. I did give her a rough time, and she sat very quietly by the side and explained to me that the hallucinations were the effect of the anaesthetic from the operation and from the drugs that had been taken for my illness.
Yes, I did suffer from hallucinations. At the time, I didn't know what they were or why I'd had them. I thought I was the only one that had had them. I honestly thought that there was something mentally wrong with me. A lot of them were completely weird, but I thought that they'd happened. I'd lived them. They were real and vivid. Obviously, because I had a tracheostomy, I couldn't communicate. Trying to explain what I'd been through, it was just about impossible. So basically you suffer in silence, because you think if you start telling people about them, they're going to either lock you up or not let you out of here.
Patients that have been in intensive care in the past have had terrible nightmares, dreams, and probably real memories of being in intensive care and found it very distressing. And they may not know what was real, what was not real, and they would say, "I've had nightmares." Sometimes these nightmares live with them for months or even years. All we can liken it to is the nearest thing that's happened in the past outside ITU is the hostages that were in Lebanon. When they were examined by psychologists and psychiatrists when they got back, they had what we call was hostage syndrome, and that's not dissimilar to what patients that have been in intensive care have. We now call it post-traumatic stress disorder. It's a very well-known disorder, and one of the features of that is they have distressing memories, they have recurrent dreams, and usually near-death experiences where people are trying to kill them. And the incidence is quite high. It can be as high as 50% of patients can suffer to some degree with that.
Some examples of patient hallucinations are often they're persecutory, and us as staff are part of that persecution. So a patient last week said that every time a nurse came into his bed space that their face was skeletal and really frightening, that they had no flesh on them, and so what he wanted to do was escape. And so we thought he was trying to just leave the unit, but actually what he was trying to do was to get away from us. So that's a really difficult thing to understand and manage at the time. It's called delirium.
Now, in the old days, we used to heavily sedate them, virtually anaesthetise them, because they wouldn't synchronise with the old ventilators that I was talking about. One of the things that's helped us is the new generation of ventilators, which actually assist the patient rather than fight with the patient. So we can actually keep the patients quite light, and the lighter you keep them, as long as they're comfortable, they will cooperate with your treatment and they're less likely to develop symptoms after intensive care. So the ventilator technology is one aspect. The second aspect is our approach to sedation. No longer do we anaesthetise them, we give them enough drug to make them pain-free and comfortable, and only use other drugs if necessary. So by keeping them awake, we've reduced that hallucination and nightmare scenario.
So we recognise that it's a really stressful time for families when their loved one is admitted to intensive care. So we've looked and worked with them over the years to provide information. So as you come to the intensive care unit, there's a guide of how to for relatives. So it's key things about what our work patterns are, how we work, but also more focused on what they can do to help us with their patient. So we have open visiting apart from an hour and a half in the afternoons, which is rest periods for the patients, which they say is really important. And they're able to come in and be at the bedside, and they're encouraged to take part in care for the patient if that's possible, but also just doing simple things like sitting next to them reading a newspaper, trying to orientate them to day and time and what's happening in the world, but also to update them about what's happening at home. We are encouraging them to bring in photographs so that we as staff can get to see the patient as a person, and that's really important for us. We also have facilities where patient relatives can stay overnight as well, and they can come in and out as much as they want to. If they want to stay by the bedside, that's okay as well, unless we need them to move for other reasons.
The effect on my wife was mainly the fact that she became very tired. She visited the hospital every day and she was by my bedside all of the time. Although she had the support of my family, my children, she still had to deal with the fact that I was extremely ill. But she showed no sign of tiredness while she was with me. But I know when I found out how ill I'd been and discussing it with the rest of my family, she was under considerable strain at that time. And I think this is the reason why she wanted to block it from her memory when I was actually discharged.
Patients that are in intensive care for the length of stay of 4 days or more, we follow them up onto the wards, and then when they get discharged from hospital, we invite them back to a follow-up clinic. At that follow-up clinic, we have a doctor, so it's Dr. Carl Waldman, and one of the nurse teams, and we invite the relatives to come as well to that. And what we do is we look at physical and psychological recovery after critical illness.
Once patients leave ITU, in most units there's no follow-up service, so the nurses and doctors have no clue whether the treatment they've given us has had side effects and what the long-term impact is. So in the clinic we find out what problems they have, and if the GPs are unable to deal with it, we are able to make recommendations to ensure their progress is not affected.
And we're just about quality assurance, really, just making sure that the things that we do here in intensive care have not got any long-term lasting effects that we should know about and can do something about. But our main role really is identifying the psychological issues that happen as a result of being critically ill and in intensive care. So it's things like identifying the impact of hallucinations and nightmares, and that's not just about on the patient, it's about on the relatives as well. And then to enable to address those issues, we bring them back to intensive care itself, so here, and we do something called a one-to-one, where we go through their events of intensive care day by day, filling in the gaps, building up their story and actually giving them the experience back. We also do diaries of intensive care, so sometimes when patients come to the unit and they have their one-to-one and there are still missing pieces, they need to have a diary written, and so what we do is we write a retrospective diary of their stay in intensive care, where they were, who looked after them, what their problems were, and day by day they're able to build that story but also keep reflecting back to it. And good examples of this is we've had teenagers in here that have returned back to school, who've had cognitive dysfunction, not able to concentrate, memory loss, and actually the schools did not understand why they were not performing. And so we printed, with the patient's permission, we printed off more diaries and they gave them to the head teachers, and they were able to formulate a different plan and support for that person. So they have other effects as well. There was an emerging theme really that collectively a lot of our patients that were coming through clinic were feeling that they were needing support from each other. We had one patient who was here for 3 months He was 42, and we looked after him for up to 18 months after intensive care, physically and psychologically. And he said that when he'd heard another patient's story, it was far more therapeutic for him, realising that somebody else had gone through exactly what he had gone through. And a legacy to him, really. We felt it was really important, a core group of patients, that we'd set up this patient support group.
The biggest reaction we get is it's just great to talk. You know, some people have actually never talked about it, and this is the first time they've actually discussed it. Some of them can't talk to their families about it, but obviously talking to ex-patients, hearing about their other experiences, they're obviously not all the same, but the majority of them are similar. So it just helps for them to find out that, yes, what's happened to me has happened to lots of other people, and hopefully we can impart how to move on, help with rehabilitation. So it's physical as well as the actual mental aspect of it.
Being part of the support group and the setting up of the support group has helped me still to deal with those hallucinations that had occurred, and also to deal with my time in the hospital and in ICU. It provides a forum in which patients can actually express their feelings of what they suffered during their time in ICU. On some occasions, those people that have suffered hallucinations had not had a forum in which they were discussed, because sometimes their families or friends didn't want to talk to them about it, and they also felt discussing them with other people outside of a controlled environment was very difficult for them. To actually be with like-minded people that had suffered the way they had allowed them to relax and express their views and feelings, and to help them deal with them. We've had a number of people that have come to the support group that had been had been discharged from ICU 2 or 3 years ago and had not had a chance to discuss them, and they went away quite relieved that they were able to allow their feelings to come out with like-minded people.
So one of the other things we do is encourage patients and relatives to express their experiences, and they can express that through talking, through writing, but also we had a young student who is a fine art student, and she was very poorly here, and her way of expressing it was artwork, and she has provided us with an amazing piece of work that demonstrates her memories of intensive care. So predominantly it's eyes, hair and tubing. But beneath that she's put thank you, and she's entitled the piece through a patient's eyes.
Part of what our support group is making things easier for people in the unit. And coming back to communication, we found that is an extremely difficult issue to deal with. People have problems writing, so what we've come across is an app that you can use on an iPad. The patient can tap on the screen, whether it's a symbol showing how they're feeling or they want to drink, or they can actually type a text. And the great thing about this is it will show on the iPad what the patient is wanting to ask or the question they've got. We believe that it's going to basically revolutionise how patients can communicate with staff, relatives, and it's something that hopefully can be rolled out across the country.
It's really exciting to be involved in a unit that is pioneering in a lot of ways, and it makes it a unit that is interesting to work on, patient focused and patient safe unit, which is the primary importance of why we're here, to make sure that everything we do for the patient is the best that we can offer. So the feedback that we get through follow-up and the support groups is important for the next set of patients that come in.
Patient experience is key. We learn from their experiences, and by just listening to their stories it connects with you emotionally, and you just understand, you get what some of the experience is like. So recently we've just been working with a group of patients, relatives and staff looking at the experience of critical illness, and we've been able to change fundamental things in the way we practice, and without knowing that experience we would never know.